Hello, welcome everyone who's already arrived to session 2 of the DASH webinar series. I'm waiting about a full minute for people to arrive. We do have over 100 registrations for this event, so trying to make sure that everyone gets in. Okay, looks like things are slowing down a little bit. So again, let's get things kicked off here. My name is Melissa Moorhead. I'm a program manager for Data Across Sectors for Health, and we'd like to welcome you to the second installment in our three-part series, Advancing Community Health through Equitable Data Ecosystems. It's offered by Data Across Sectors for Health, which is a program office co-led by the Illinois Public Health Institute and the Michigan Public Health Institute, and funded by the Robert Wood Johnson Foundation. This webinar series introduces our conceptual framework, which highlights some key domains of shared multi-sector data landscapes and helps, we hope, to guide communities in leveraging their data systems for equitable systems change. In the spirit of all teach, all learn, we highlight lessons learned by and from our awardees that we found illuminating and that we hope can light up other projects and future discussions on the critical considerations regarding data and equity. So we have some tips on using Zoom. We're still learning them, some of them ourselves. We are offering American Sign Language interpretation. So our helpful interpreters are pinning their video to your screen. You may be able to adjust your screen view to speaker to make sure that you're able to view those interpreters. Because we have sort of a large crowd today, we are using the Zoom webinar. We do encourage chat for saving your questions or asking your questions as they occur, or using the Q&A module to submit questions to presenters. But we are asking you to sort of think about them as they occur, and we'll have a Q&A period after the actual presentations. And then we'll facilitate a more informal chat afterward. This is why you may have noticed that you got an updated Zoom information that made the whole webinar longer. That's so that we can have that sort of informal after discussion for the for any other questions that arise. So thanks to our presenters for that. If you do need technical assistance, if you go to the chat function, you can look for Celestine. She is our technical producer today, and she should be able to help you work through any issues you might be having with Zoom. So again, here's a little reminder about who we are. We will be sending out this slide deck after the event to all participants, and then posting a good deal of the information on our website. So we are sharing a lot of slides that are meant to be referenced as well as help walk you through the story. So to get started with the framework itself, we have been doing a lot of work in this area for the last 6 years. And so through insights from our awardees, national inventory surveys, a network called All In Data for Community Health, and other program offices, DASH has started to identify some key factors which are important for sharing and using data across sectors and with community to support more equitable systems that create the conditions for health and well-being. In this version of the DASH framework, we are trying to dive deeper into how equity as a process and an outcome intersects with data ecosystem and a data infrastructure that is built to unlock the power that data ecosystems can have towards social good. This framework includes some fundamental components and intersections of data sharing, such as factors that support strong data sharing foundations as well as recommended components of data ecosystems that facilitate that data sharing. So the main factors that we've identified relate to building foundation with community. There's the actual shared data ecosystem that is sort of a description of how data gets shared and used across communities, but we have some deeper dives into that. We're very interested in the role of policy in this multi-sector approach, as well as the impact that market drivers can have on it. That's sort of the external components across the top. And finally, all of this being leading towards equitable systems change is what we're hoping to do. So that by connecting those, all of these information systems and then sharing data across sectors, particularly in ways that are community driven and accountable to community members, hopefully will drive meaningful, sustainable community health improvements. On our first session, which you can access through connect.org, we focused on the building foundations with community. Panelists from our funded communities discussed the challenges and complexities involved in relationship building, as well as opportunities for establishing relationships among partners and the community. So for today, we are honing in on some of the actual work. Sometimes we refer to these as use cases. We'll be focusing on the what, the who, the how that both enables data sharing and collaboration and can be the output of that data sharing and collaboration. When organizations in a community are forming partnerships and sharing data, they can begin to manipulate the data ecosystem itself to enable better outcomes for systems change and equitable community health. Emerging from efforts taken by well-connected actors, you'll hear some more about that. These putting some more intentional design and designing equity into these ecosystems becomes a way to really promote community thriving. So the goals for today's session include understanding how to apply an equity lens to the entire data cycle or data ecosystem, particularly through engaging people with lived experience of inequity or people with experience and who live in the community in this whole data sharing process. We're hoping to hear some of the lessons learned from the iterative process of developing and implementing components of a data ecosystem or project that will impact data sharing initiatives and your community. And also we will be identifying various components of that data ecosystem and how the components interact with each other. So to kick off the presentation, we have three presenters talking about two different communities that are working on building out an equitable data ecosystems. They're offering us their insights and lessons learned on those foundational aspects of a shared data ecosystem in ways that are helping to promote health, equity, and ultimately community thriving. So we're going to start off with Chad McLeod and Jess Maurer from Maine. Chad is with the Health Information Exchange called Health InfoNet in Maine, who together with Jess Maurer, the Executive Director on the Maine Council on Aging, are working on a community-driven approach to what is called a community information exchange, which I will describe in more detail later. Following that, we will be hearing from Milan Chaitani from Boston, who has worked on what's called the Vital Village Networks, leveraging technology to show and leverage community data to promote a more equitable system across the region. There are others on this call who have expertise of their own. We do believe that there's a lot of knowledge in the room. So again, if you're comfortable using chat, we hope you will drop questions and introductions in there. If you're more comfortable on a face-to-face, particularly with the interpreters, we would be happy to have you raise your hand during the Q&A portion or the conversation, and we will allow you to share video. So with that said, Chad and Jess, why don't you take it away?
Terrific, and thanks so much for inviting us. I'm going to talk for a few minutes and then turn things over to Chad, and then we'll wrap up before we turn it over to the next speaker. So I'm just going to really share a little bit of our process to get us to where we are here in Maine. And again, Chad will go deeper in our thinking, and then I'll sort of talk through the next phase of our work. So in 2020, the Maine Health Access Foundation and the Maine Department of Health and Human Services, including our Office of Maine Care Services, which is what we call Medicaid, convened a series of discussions with a broad group of stakeholders to discuss how they were currently sharing social health data or thinking about sharing social health data, and to learn more about what tools and approaches organizations in other states were using to share person-level information and make referrals between healthcare and community-based organizations. I'm so sorry. At this moment in time, this nice little fly has decided to like dive bomb my face. So sorry about that. At the time that we convened this first stakeholder group, there were several healthcare systems in Maine and social service organizations working to look at ways that they could screen people for social health needs and connect them with social supports while tracking referral and health outcomes. Since Maine has a very small population, we're 1.4 million people, all total, and is the most rural state, which means we're really spread out. There was a real interest in ensuring that whatever was created for this sort of information sharing would work for everyone and be accessible for everyone and to everyone, including our rural service providers who really don't have access to technology platforms. They're still tracking stuff on Excel spreadsheets. So these early stakeholder conversations, which included leaders from all of our major health systems and social service agencies, and also many organizations that serve people who have been historically marginalized, particularly, and have had negative health outcomes because of that marginalization. We were able to create a working group of volunteers. Really, and I will say most of the volunteers were engaged at some sort of advanced thinking about this kind of data sharing between entities and safeguarding that data. And so we got a core working group of about 12 people who agreed to work on creating a shared vision and begin laying the foundation for the creation of a community information exchange in Maine. This work group met in 2021 and was funded with administrative support through the Maine Health Access Foundation and a Dash Mentee cross-cohort learning opportunity grant. We started our work and remain focused on creating a statewide community information exchange that includes all populations and pays particular attention to equity issues. With that said, we focused initial discussions and even our first few use cases on older adults, really narrowing the conversation and creating a starting point, but not in no way reducing the broader scope of the project. Here at the Maine Council on Aging, we're actually building a strong understanding of age equity and are using this framework in this project, particularly because of the enormous cost of ageism in healthcare, particularly both bad outcomes for older people as well as to our economy. So the broad goal of the Community Information Exchange, CIE, as developed by this initial working group last year, is better health through improved information, referral, and coordination. So that's sort of the vision. The group agreed that the functionality of the CIE should generally include the ability to collect health-related social risk information using a shared language, and compile and share this information individually with permission, obviously, and in aggregate. Meaningfully refer individuals seeking assistance to providers of health and social services using an interactive resource directory platform that allows for real-time and asynchronous closed-loop communication, analyze results and take action to improve care coordination for people, make the best use of resources within health and social service organizations, and address unmet need in communities, particularly focused on increasing health equity outcomes throughout the state. So some of our most critical pieces of work during phase one was to get everyone invested in the idea that there was not going to be one technology that was going to be used, that previous investments, particularly in technology and in systems that have already been created, would be honored and integrated into this idea of a CIE, and that the voice of people, especially people from marginalized communities, needed to be fully included in the work. Ultimately, the group, through a 6-month process, reached consensus on recommendations and issued a report. And everybody in the process fully agreed to participate in phase 2 of the planning process. Before starting phase 2 of the planning process, we convened the larger stakeholder group again of those 75 people, explained our process and shared the report and the recommendations, and had a robust conversation with really ultimately people leaving very excited about the progress that the project has made, and understanding the role that they could play, how they could plug into the process in the future. So the next slide is the roadmap that we have used. I should have forwarded that a little while ago, but is the roadmap we've used from San Diego's 211 CIE project. And it's really, we haven't followed it specifically. I mean, like to the each step chronologically, but it's really been our process guide. And where we are right now is really heading into step 5, which is building the framework, with a lot of work done on step 3 and some work still left to do on step 4, particularly in creating use cases that can help the general public and specific populations understand the value of the CIE. So I'm going to turn things over now to Chad, who will go deeper in the process and initial recommendations, and then I'll wrap up and let you know what we're up to.
Well, sorry to interrupt, Chad, but before you get on, I am here or seeing that we have had a problem pinning the interpreter to the screen. So I've tried to pin them since I am the presenter. And I know that you all are also on Spotlight. So if there's anything else we can think of to try, I just wanted to elevate that to our tech team. And I'm really, really sorry about that. We will continue to work on it. And hopefully the video will show the interpreter as well. I know that's very unsatisfying, but thank you for raising that, and we will continue to work on it. Go ahead, Chad.
All right, super. Thank you. Thanks, Jess. And I'm going to stay off video just because my internet's been a little sideways today. Hopefully that'll mitigate any risk of me crashing. So again, my name is Chad McLeod, and I work with a company called Health Infonet, which, as Melissa mentioned, runs the state of Maine's statewide health information exchange. So that work closely parallels that of a community information exchange. So I'm glad to be here today to share a little bit more detail around what Maine's doing to bridge its clinical and community healthcare settings. Melissa, next slide, please. So the chart shown on this slide is another that was taken from the San Diego CIE group, which really starts by defining what a CIE is so that we have a shared understanding. I'll speak over this, but since I come from the HIE world, I'll say that the two models are very similar in that they are designed to share person-centric information and the value of improving the quality, safety, and delivery of care. Though because the HIE, the Health Information Exchange model, has often exclusively included stakeholders from the medical field to benefit from its services, adopting that legacy health information exchange term to describe the level of cross-sector collaboration that's required to address more social health related factors is seen as a risk to over-medicalizing economic hardship and alienating those community-based stakeholders. So the first step in breaking through the boundaries reinforced by the medical field's conventional use of HIE is to bring forth the concept of community information exchange. The CIE concept expands on the traditional HIE model through the creation of an ecosystem that, as Jess mentioned, is comprised of network partners, a shared language, and an integrated technology platform that compiles and aggregates individuals' social health information alongside any other information that could perhaps tell a story about that person's health, wellness, and well-being. This effort is coming to be as a result of increased recognition that the status of an individual's health is more than just the sum of their clinical encounters. And though the types of services that a CIE may offer can vary depending on the region in which the system operates, the mission of any CIE really remains the same. It's to encourage a paradigm shift in the way that care is delivered by expanding the definition of what it means to deliver comprehensive person care. So again, individuals whose health information is shared through the CIE benefit from the framework's design by only having to tell their story once, of their risks, of their needs, their opportunities, their barriers to their various cross-sector providers. Next slide, please. So just mentioned both of these. I'll just recap with that understanding of what a CIE is, that stakeholders in Maine from healthcare and social services backgrounds came together to begin to define what that CIE looks like, and we'll dive into those details momentarily. But the high-level goal, again, was to share or to define a shared vision and framework for the further development of a CIE that all could agree to and work on collaboratively. And our vision statement reads, to better the health and well-being of Maine residents through improved cross-sector information sharing, referral exchange, and care coordination by shifting from a reactive to a proactive approach to providing person-centered care. So what does that all mean? Melissa, next slide. Okay, so there are quite a few components involved in building a successful CIE. There are many examples across the country now that we've lent some guidance from. And in Maine, we broke down that framework into 8 core components that we'll walk through today. So the first component is called community engagement and consensus. And this component is really all about bringing the right people to the table who have a role in providing critical care services to individuals. And as just mentioned, for the purposes of getting a CIE off the ground in Maine, we defined our initial CIE use case to focus on the older adult population. This decision comes as a result of various long-term supports and services related data sharing projects that are already in progress throughout the state to address our aging population. Stakeholders in this domain vary, yet bridge the health, social, and public sectors, and are well positioned to touch on the various micro, meso, and macro processes at play when we talk about understanding a person's health, wellness, and well-being. With stakeholders and an initial use case defined, the next step is to define the data inputs to an individual's longitudinal health record. So that means what kind of data and received from who and where would be valuable to be included within a health record specific to an individual that spans all of their various locations at which they've received care over time. Think of the various health, social, community, and public information that is collected on individuals throughout the state or a particular region to describe their health, wellness, and well-being. That's the data that we're considering in this process, right down to the specific data element. Once we figure out the who from the community engagement and consensus component, the what from the longitudinal component, the next is to define the when, why, and how much per the data governance and person consent process. In short, this is perhaps the most important component of this whole framework. And in this process, we define patient consent policies, data security and privacy considerations, data authorization, provenance and ownership principles. We talk about patient stigma concerns, health equity considerations. and literally any other detail that comes down to the legality and ethicalness of operating a CIE from a participant or a person, patient, client perspective. And at the end of this process, we'll have examined and defined our guiding principles, and we've probably already set up some governance committees to oversee and manage these changes and impacts over time. At this point in the CIE framework, we figured out what we want to do and how we can do it from an operational, legal, ethical, business perspective, but how do we do it from a technical perspective? And so the first step is to determine how can we take that longitudinal health record shared definition established earlier and translate our data sets into definitions that folks across systems of care can understand. What does an ICD-10 code mean to a food bank? What does a CPT code mean? And thankfully, we have a couple of different groups that are starting to flesh this out for us. There's the US Core Data for Interoperability Standard and the Gravity Project. And so those are two standards that we're looking at as part of this process. At the same time, we need to determine the precise data infrastructure to connect all of those dots. And like a health information exchange connects disparate EHR systems throughout a region to build a shared electronic health record, the CIE should do the same by connecting diverse databases to build a combined clinical and community record. Key to this effort is in how the infrastructure can support participants at varying levels of infrastructure maturity. And like Jess said, that means that some organizations may still be logging that health information in an Excel spreadsheet, while others may be using more sophisticated technology. And the CIE needs to be adaptable enough to collect information from both systems with minimal invasiveness. Once the shared technology platform is created, the defined longitudinal health record should be made available to authorized CIE participants in an online forum. And then on top of that, the CIE can then build a variety of value-add services. And just like Jess mentioned in Maine, we've narrowed that scope to implement a universal social risk screening tool, which really just means that we're going to give access to our participants to a certain instance of the Prepare tool or CMS's health-related social needs screening tool. We also will create a resource database like a 211 directory, a closed loop referral management function, and some clinical and community notifications. Lastly, all of this is leading up to community care planning, which is the operational phase of the CIE, the top of the pyramid, meaning that all functions and services built are designed to facilitate and encourage a paradigm shift in the way care is delivered. So what does all of this mean? So each of us require different types and amounts of services to improve our health, wellness, and well-being. And available health-related resources to assist us vary by county, city, neighborhood, and personal situations. So we have to think more creatively by building solutions that can forecast, prepare, and proactively respond to emerging risks and needs, like what a community information exchange is intended to do. And community information exchange at the same time will hopefully help eliminate some of the racial, ethnic, socioeconomic, geographic, and age disparities to help improve access and outcomes of care. So the last thing before I'll shift over to Jess again to wrap up our portion of the presentation is to give a quick use case to kind of bring this all together. So let's say that an older adult is gaining weight, experiencing anxiety, and has an unusually high blood pressure reading at their most recent primary care visit. They've also recently lost their driver's license, which is their primary means of transportation. So the older adult presents to their PCP office, and the provider may perform a social risk screening assessment through the CIE in order to identify any present social health risks. Upon doing so, the provider may identify food insecurity as an issue for the older adult. The primary care provider then uses the CIE's centralized resource directory to refer the older adult to a local area agency on aging that operates its community's Meals on Wheels service. The area agency on aging receives the referral through the CIE and then closes that loop by contacting the older adult to begin meal services. Additionally, due to the patient's high-risk medical conditions, the area agency on aging provider may sign up for real-time notifications to alert them when the older adult is admitted to or discharged from the hospital. So the area agency on aging is able to A, prevent food waste, while B, ensuring meals are available to the patient when they need it the most. So with that, I'm going to pass it back to Jess, who can talk a bit more about phase 2.
Thanks, Chad. I always love hearing you talk about this, even though I've heard you do it a million times. So thank you. So just wrapping up sort of where we are now, the initial work group proposed that a neutral convener provide facilitative and administrative support for phase 2 of the planning process. And so somehow I managed to raise my hand and say, we have no interest in ever running the CIE in Maine, and am happy to be the neutral convener and oversee the project. And so we have hired 2 project coordinators to assist us with this work. And we really are just getting started with phase 2. And what we have done is convened a steering committee, which is really balanced. It includes the prior members of the working group, and we'll be adding a few people to this group representing some additional historically marginalized communities, and at least one person with lived experience. We want to make sure that the steering committee is balanced between governmental, community-based services, healthcare, and consumer community leaders. And this will be the decision-making body. And we've already appointed a leadership team with co-chairs, one of whom is a leader in healthcare, the other in social services, who's already doing the leader in social services already doing some information sharing with a federally qualified health center. The leadership within this structure is governed by a memorandum of understanding, and that memorandum really lists out the responsibility of tasks and overall outcomes for the project. The steering committee is going to populate and create a work plan for 3 committees: legal and policy, governance and cost, and data and technology. And these 3 work groups will really engage community members of all types, really focused again on including people with different backgrounds and different social health needs, so that we're really creating a robust conversation within each of these work groups. And they'll also include social service providers and healthcare providers as well. We will also be in the next year creating, in the next few weeks, months, creating a provider network, as well as an advisory committee of engaged community voices with lived experience who can help inform and participate in our decision-making processes. Ultimately, we have all agreed that we're going to strive to develop community trust in the process and throughout every aspect of the governance and decision-making in the CIE process. Finally, you can look for a report in a year from now on this process, and we'll be certainly looking at the successes and challenges, and hopefully moving toward implementation of the CIE, maybe even sometime next year. So that's the end, and I look forward to the next presentation, and then having time with y'all for questions and answers at the end.
Thank you very much. I'm going to hand over the screen sharing to Millen. So Millen, when you take it over, could you please pause for a moment? And I've asked an attendee to let us know that the interpreter is still pinned. So I'm seeing the interpreter, and yes, great. Thank you.
Perfect. Great. Thank you for the introductions, and also for the confirming the tech is working today. My name is Milan Chitani. I'm a data analyst, and I'm here on behalf of the entire Vital Village Network, a community of resident leaders, organizations, and agencies in Boston committed to maximizing child, family, and community well-being. We know that the answers to challenges facing Boston neighborhoods are in the community, and so we support community initiatives and family leaders to achieve structural change. Our network works on a range of topics, from food justice to creating leadership pathways, advocating for breastfeeding, equality and equity, and increasing family supports for parents. But today I'll be sharing a little bit about a community-driven data tool that was created for housing equity and how our network co-created it with community leaders to share data stories. So some of the key learnings that we're hoping you'll take away from today are that community leadership is critical at all stages of creating a data story. The final decision-making process needs to be in the hands of community members at all times. Everything from brainstorming and ideation to the dissemination of the final tools. Community-driven data means broadening your lens on what is considered data and information, as you'll see. And also continued informed consent is critical to successful data storytelling, especially when talking about qualitative work. So we'll start today by talking a little bit around what is a data story. I'm going to share one definition of many, which was created by our partners at Children's Health Watch and Vital Village's national partnership, the Networks for Opportunity in Children's Wellbeing. A data story serves as a tool for positive change, translating information into a compelling narrative tailored to a specific audience. Data stories occur when a community develops an intentional narrative about why policies, practices, and programs are needed to rise above a particular challenge. Narrative strategies that illustrate a process or historic trend, describe relationships or structures, and make the case for a key message. So one thing that stands out in this definition so far is that information is not limited to numbers or to photos. There can be a wide variety of different types of data. Data can be audio storytelling or videos. It can be maps. It can be whatever compels someone to move as a coalition together towards a common goal. Community-driven data stories focus on the solutions that are created in communities rather than describing the problems themselves. And they can be utilized as an intervention and used to evaluate community progress. Tracking metrics can help highlight community strengths and collective efforts, giving voices to experiences that may otherwise feel siloed off. And so with the community housing data tool, we hope to bring together a coalition of leaders to bring this data story to life. Families in Boston have faced challenges obtaining safe, affordable, and high-quality housing. And for people living in unsafe conditions, there's an urgent need to connect with community initiatives that can help improve conditions in their homes and in their neighborhoods. Questions like what to do if there's high lead levels in a neighborhood, who can help with removing lead pipes, what to do if there are environmental exposures to mold or pests that are triggering asthma in high rates among young children. Community members in Vital Village networks raised these challenges and came together to form a community data work group. And of note, one community member who is focused on promoting needle safety, their granddaughter was in a school where another student experienced a needle prick. And the students at the school came together to advocate for needle safety and to raise awareness and shine a light on a broader challenge and trend that isn't just one individual's experience, but a broader challenge together. So for each challenge that's highlighted in this tool, each spatial and health disparity, there are hundreds of community leaders that have been working to push the needle forward and make change. And it was critical that we use the strength-based approach to highlight the existing community resources. Our goal was to provide resources to individuals, families, and organizations about the state of housing in Boston communities, making a tool that's user-friendly and interactive and easy to use on mobile devices and laptop computers. The data visualization should be used to support personal decisions about where someone could live safely, but also community advocacy and pushing the needle forward on systems change and equity. So two tools that we use to develop the community housing data tool, thinking about the data ecosystem of this webinar. The first was around sharing data for population health advocacy, linking health-related data with housing data, creating different forms and mediums for sharing information around maps, and again, using means to elevate and highlight community strengths. But most importantly was that all of this work was led and driven by the community data work group, which consisted of diverse individual and organization partners that, as we mentioned before, were heavily involved from the onset of this project until the final dissemination. The community data work group met monthly, and at the start was a space just to build trust and in coordination between members. The Vital Village staff took a step back, and work group community leaders ended up facilitating the space and guiding the conversations each month. After the first few meetings where trust was built, the group focused on identifying key messages. So on this screen, you can see a couple of the themes around support systems that came out of the early conversations, as well as 3 specific populations that the work group was trying to support. So in-house quality and safety, community, external and safety and quality, different forms of stability support with housing, especially around evictions, and then accessibility and affordability were common themes. And some groups that we hope to support and highlight were the experiences of single fathers, of returning citizens, and of residents with asthma. From those topics, the work group convened and identified specific metrics and goals to share a story about in this data tool. So from the in-house quality and safety topic, blood lead levels and smoking prevalence were the key metrics that people wanted to explore. As I mentioned before, needle safety, crime density, and community resources were all critical around thinking of external community quality and safety. Rental burden was a big topic, especially not just showing the challenges with eviction, but also the community groups that are supporting and providing eviction-related resources to people facing unstable housing. And then finally, the 3 groups around Boston residents, we were focusing on housing inspections around the conditions in homes that may be triggering asthma. Stories from the community were important for returning citizens, and then trying to compile resources for single fathers. We face challenges with finding data for all of these different topics. Community-driven data doesn't just mean having community members involved in collecting the data or defining it, but also in thinking creatively about what data is not present in ways that we can still share a story in a compelling way. Well, as you'll see in a moment, the piece around returning citizens and single fathers in particular was difficult to find data sources, led to qualitative work to share those stories. I'll do a brief demo of the data tool, and I'll focus on the needle safety maps that came out of this work. So as I mentioned before, the experience of individual needle pricks was indicative of a broader trend across Boston neighborhoods. This map shows neighborhood levels, neighborhood calls to 311 for needle pickup requests by census tract level. So you can see that certain neighborhoods have more requests than others. If you look at the city of Boston as a whole, you can't see the individual pockets of success and challenges that specific neighborhoods or regions are facing. We also tried to highlight specific things that are going well. So not just the challenges of where there are many needle pickup requests, but also spaces where there are community drop-off sites. We also tried to highlight schools and playgrounds to give a face to the name and to the experience of many of the children living in neighborhoods. And then finally, down below, we provide information provided by community members of what to do if you experience and see a needle in your neighborhood, providing resources and elevating community resources. So going back to what I shared before, sometimes data sets, quantitative data sets are not existent to share this story in a powerful way of people's experiences. And so out of that came a desire among returning citizens and storytellers to share a story of housing after returning from an experience of incarceration, share a story through another means and through audio storytelling. On the housing data tool, you can find the full story in video. I just wanted to share an excerpt in the beginning about the process that a few community storytellers were using to share their stories, along with some Vital Village staff who are in the audience here. Let me actually try to stop sharing and reshare with the audio. One moment.
The best way to know if you have a good story, one is to record yourself doing it. The other part is to have someone else say your story out loud back to you. So that's what we're going to try to do.
And so with the data storytelling component of the housing data tool, data ethics and consent were especially critical. The agreements drafted before the workshop and storytelling were drafted by the storytellers themselves and by community facilitators. It was critical not to only know about where the story will live once it's completed, but also how long the story will be shared. How is the narrative told? And options to opt out of sharing the story at any time if in the future it doesn't feel right to have this story on the website. We also discussed images and sounds, ways that storytellers can have complete ownership of the final product that's being shared out with the community and with the world, as a way to create additional ownership and to make sure that advocacy was rooted in people's lived experiences. Here's another example of ways that the data tool disaggregates by geography as a form of equity. We talked a little bit about it with the needle example, but blood lead levels is another situation where the statistic for Suffolk County as a whole in Massachusetts doesn't tell the complete picture. On the left side, you can see that 22 per 1,000 children have blood lead levels above a high risk level. But if you break it down by neighborhood, you can start to see some neighborhoods have much higher levels than others. Also, you can start to see that certain neighborhoods are pockets of success, areas that are surrounded by other neighborhoods that may have higher blood lead levels, but have a statistically significant lower rate. And so this tool has been used also for community advocacy to highlight successes and also areas and opportunities for improvement. These data tools are used by community work group members to advocate for policy change, for their own individual decision-making. District level policymakers have requested maps specific to communities in Boston to advocate for additional resources, such as more needle pickup sites or improved resources and funding to community initiatives. There's also been peer-reviewed academic articles published from this data source, and the maps are shared out in community meetings by activists. Another example of the community data work group, a data tool that spun out of another cohort, was the Abundance Boston Food Justice app, which came out of a vision from community members to see a tool for families to find up-to-date information around food resources in their neighborhoods. The same process applied here, where people were leading the work group and the data tool from inception until dissemination, where families can leave reviews for locations and provide input on their experiences. The tool was created by Boston residents and government partners and Vital Village staff, but has also taken a life of its own and being shared out and disseminated more broadly. Right now, the Abundance app tool includes information on 350 affordable or no-cost groceries, food pantries, food resources that are run by community members in Boston. There are free meal sites, and also highlighting, again, the strengths of communities, organizations that are promoting food justice. So this is a tool that's available on mobile applications as requested by community members to be able to see a broader context for food justice in their neighborhoods and to improve advocacy and funding and raise awareness about the amazing initiatives that have always been going on in different neighborhoods. So in closing, I wanted to leave everyone with a continuum of community engagement that leads a lot of our work at Vital Village. On one hand, you can see inform, which would be a type of engagement where you're providing community members with information. We try to avoid this as much as possible and instead go to co-creating and empowering with data tools, partnering with community members at each aspect of the decision-making process from inception to implementation, and placing the final decision-making in the hands of community members. So we want to thank all of our partners who helped to build these 2 data tools you saw. And thank you all for listening today for the presentation.
Well, thank you all very much. And I'd also like to thank our audience for patience and some grace as we have been working through making sure that we have our interpreter visible. For all of us who are in various stages of our equity journey, I hope you know that we share that pain and of when we don't reach our goals, and hope to be able to continue to do better in the future. So I'd like to especially thank our interpreters. Lori right now is very good at helping us think through the impacts of how we are presenting to make sure that we are as inclusive as possible. So that said, we are open for questions. We clearly have some work to do in managing our video. So if you aren't comfortable using the chat or the Q&A, please raise your hand and we will try to make sure you can get on camera and audio. And I am checking the Q&A right now where there is a question that just came in for Millen. And then I also have a number of questions in case we need a few more, but yes, thanks again for helping us work through this process and asking your questions, however you are most comfortable. So Millen, what advice would you give from your experiences to communities, moving your projects from informing communities to empowering communities to participate?
That's a really great question, and something that I feel like we're all learning every single day to improve on as well. I think what guides a lot of our work is knowing that the answers are in the communities and that there are existing initiatives in every community to address every challenge that we may be working towards. So finding the right coalition to build together, creating space to step in and create space, but also to take a step back and listen to others, to show up for other coalitions and groups that are leading advocacy and trying to find common ground to lead together in your work. With our community data work groups, it's always been challenging to create a space and to build trust in the community. So the community work groups have been going on for since 2015, and many members of the Vital Village Network have been leading the network since early 2000, around 2010. And so it's a long process to build that trust and to make sure that everyone feels welcome leading and contributing to these initiatives.
Yeah, that's great. Thank you. I think this next one is also for you and might be sort of on the continuum of that same approach. And it involves the what you presented in the creation of the dashboard illustrating needle exchange sites and where incidents had happened. An attendee would like to know, how were the people who use substances included in that visualization, and how did you incorporate stigma reducing language and approach to making that publicly available?
Absolutely. So I see the first question around the creation of the dashboard. Again, we recognize that there are community initiatives that have been working with populations to reduce stigma-inducing language and making sure that their voices were centered at all stages of the of the build out of the tool, and especially around finding the language, the text for the final tool was really critical. In terms of whether people who were injection drug users, whether they were involved in the creation of the tool, I'm not 100% sure, but I can follow up soon.
Great, thank you very much. We also have a question about your decision to center youth in community voice as opposed to a different group such as the injection drug users.
Mm-hmm. The community members that were leading the group as a part of, were leading the build out of the tool as a part of the work group were community members who were most closely connected to the youth that were experiencing the trauma. And so because they were the ones leading the tool's development, we were supporting their vision for what the tool could look like for advocacy, for creating the safe pickup sites around the city.
Great, thank you. I think the next one is for Maine. If you all would like to start sharing your video, and we have a interpreter handoff. Thank you very much. This is a question about how you started, or how would you go about working with a community partner who declined to share information with the Community Information Exchange, or maybe who didn't agree to do it initially.
Jess, do you want me to start? So there are a couple of ways to kind of show folks the value proposition of the CIE, and I'm speaking from a technological perspective. Jess may be able to speak to the business perspective more, but for example, there are tools like Find Help or tools like Unite Us, which allow different services to be available to in-network providers, which are those that are actively engaged and participating, versus out-of-network providers, those that we know, for example, exist in our community but aren't, participating in it more closely. And so in the example of closed loop referrals, for example, if a provider wants to make a referral to an out-of-network participant, you can still send that participant an email or perhaps give them a call on the phone, but that referral won't be tracked technologically through the CIE system. Over time, if that out-of-network provider is receiving a lot of action through this closed loop referral mechanism, they may be enticed to just use the technology or to buy into it a little bit more closely to benefit from it like the other in-network providers are. So I think it's a matter of not expecting to get everybody from the get-go, but demonstrating the value proposition of it over time. And I think that will kind of prove itself in the long run. Jess, would you add anything to that? Open, you're on mute.
Shoot, it's twice in one meeting. So I kind of heard the question a little bit differently. Maybe that's because we come at this a little bit differently. So I heard it from a consumer point of view, and I think the answer is a person should always be able to decide what information is shared and what information is not shared. And so I totally agree with what Chad said in terms of the provider piece. I would also say that we want to build the network so that it's the referral process and screening process so that it is self-navigable so that you can participate in screening your health needs and finding the right supports for you, and that you can make a direct referral and decide to participate with one, for instance, an area agency on aging or a behavioral health provider without sharing the data, for instance, with your healthcare provider. And so we would be building the system out in ways to allow for that to happen. So, and if we're talking about providers, I totally agree with Chad's response.
That's a really fascinating and exciting approach to having that more granular control, and I appreciate that you both answered it. That said, we are at the bottom of the hour, so the official webinar is over, and the Q&A can continue. However, thanks to the generosity of our presenters, and we do have some more questions coming in. So thank you all for participating. Again, we will be sharing out the recording, some resources, and encourage you to look for them on your email and on our dashconnect.org site. Meanwhile, it looks like our next question probably is directed more at Millen, asking if Millen can speak more to small data and disaggregating data without risk of identification of individuals. So I think that's starts out a technical question, but then I also think that there's a really powerful add-on at the end, which is how did you handle that conversation with the community? So
for our housing data tool, we actually were using larger data sets. There was nothing that was, there was no PII or individual health data shared. The smallest data sets were all still aggregated at census tract levels, and we're coming oftentimes from government partner data sources, groups that community members would request specific data, and different public or private organizations would help us get there. So with the needle pickup sites, for example, it was aggregated 311 call requests that were coming into United Way at the City of Boston that were being shared back with us, aggregated at the census tract level. No individual information was there. I think that I want to pass it over and give the opportunity for Chad or Jess to respond if they were using more individual level health data.
But when I wanted to just sort of chime in to sort of say, you know, it's for me anyway, the impetus to move toward a community information exchange is that we have such little data, population health data, real data available to us at the community level in Maine, because we have, when I say we're the most rural state in the country, we have 9 communities that have more than 20,000 people in them. And so, you know, mostly when it's very difficult to disaggregate data. And so this will help us identify both gaps in our system, will help people be able to, and so there's a lot of process behind all of this, right? So it will help people right now. When something happens, there's no mechanism, for instance, and Chad and I are working on a project that sort of informed a lot of this work, but when somebody falls in Maine and is not transported to the hospital, that information just goes nowhere. So there's no intervention at all. And so we're building in processes to this process that will allow for at the fall site getting permission to share information, for instance, through this network, which would be really helpful. So I think we're going to be able to combine some pieces that will allow us to use individual data, but we won't be able to see that, but we'll also be able to have more data at a local level around what the challenges are on an individual basis based on consent. So it's a different model. It's a little confusing, but anyway. Chad.
Yeah, I think I agree with everything that's said, and I'll just speak to how we do this at the Health Information Exchange when we don't want to identify folks at an aggregate level. We use the rule of thumb that if in any ways that we're stratifying a population across any variable, there's less than 11 people within that subunit, we de-identify it totally, and we don't provide access down to that detail. So it does prevent you from at any moment, knowing the 2 people that live in a rural community, like Jess said, and being able to identify them despite it being quote unquote de-identifiable information. So That's the rule of thumb that we take with health information that's lent from the CMS standards.
So I appreciate that you jumped on into answer that, and that all of you have thought about this a little bit, because that was actually one of my first questions as well, regarding to what extent did you feel it was important to make sure that participants and community members understood the data and technology involved, and sort of what was at stake. And that can get really granular. I'm curious about, did it take a lot of time, and do you think it should take time? Should you have, what kind of lessons learned do you have from that?
Yeah, so I'll start. With the CIE work, we have work groups that are intended to kind of flesh out the project plan associated with community information exchange. And then within each of those, we're hoping to receive some consumer community person buy-in, like the folks whose data is actually going to be shared through this platform has to buy into it. And if we ultimately don't get that buy-in, we're not doing our job, right? And so I think we'll take the time it needs in order to establish that comfort and understanding of how they want their data reflected in the platform in order to move on along with the next steps there.
And we found just in initial conversations that, the people aren't shy about sharing their thoughts about how information should be shared. So I think I think our biggest challenge will be coming to consensus on various different aspects of sharing. And some people, we want to build a system. Some people may be willing to share some pieces of information and not be willing to share other pieces of information.
For us, the same applies around the consent process being critical to all data, like dissemination in that aggregation process. So there have been also cases where we've aggregated to neighborhood levels or to larger groupings because it's more informative to see cases by a specific neighborhood than by where the boundaries are defined by community members instead of boundaries defined by an external data set that's coming in, like the census boundaries. And I think that also goes down to consent about making sure community members are involved with the decision to share data in specific ways, to aggregate or to disaggregate in different levels. I also, I made a mistake earlier. I said United Way, but Boston 311 is actually a service provided by the city for phone calls for emergency situations. It wasn't United Way data.
Well, thank you for the clarification. There is a question that I'm about to read, but I would encourage someone whose name I wish I could have some help pronouncing, Devea, I believe is what it looks like to me, to maybe raise your hand so we can take you off mute in case it needs clarification. And before we go there, though, I did want to probe just a little bit deeper on this sort of beyond consent and into remaining accountable to the community members who have been participating so far in your dashboard work and in the CIE work. What's the, is there an ongoing way to make sure that as people's understanding of the impact of their consent and data sharing work evolves, that they continue to have a voice in that?
I'll just say that we are trying to create an iterative process and include people with lived experience in both an advisory capacity and a bigger, because you met one person of any kind, you've met one person of any kind, so you can't have 1.4 million people on the committee, but so we want to have a robust advisory committee and make sure we have people representing enough groups of people in all of the work groups, so that as we're making decisions, we have touch points, and we're making, we're checking in with the advisory council after, there's been a process, and then there'll be an opportunity for feedback and decision making. We are not down that road yet, so we haven't gotten there. I would say we're not there yet. So we only have a commitment to a process right now, and so we'll be able to answer that question probably a year from now.
For us, we always have written agreements that are outlining different roles and responsibilities, and also to hold ourselves accountable to make sure that we're following up with different commitments to community members. So for the qualitative work for that workshop with returning citizens, the agreement was drafted in writing by storytellers and by the facilitator to outline what their goals were for sharing the tool, why they're doing the work, but also what the expectations were for those questions that we brought up in the slide. So having it in writing has helped us to make sure that we're checking in regularly, we're holding ourselves accountable as a network, and that the storytellers always feel that they have a contact and a place to go if things change in their comfort levels with continuing to share those videos.
Great. I'll go ahead and skip Divya's question one more time, because we do have another question about the consent piece, about whether you found it to be a lengthy legal process to establish governance with community members. And was there ever a need to provide funding for a partner's legal review?
That for us, Melissa, would you say? Yeah. I would say for right now, for the CIE, we haven't really got that far in the process to know the answer of that. But I do think that this kind of takes a different form depending on whatever decisions are made along the way. So kind of tough to say. I would say for the state of Maine's health information exchange, just as an example, consent has been put into state statute. So there's some state support behind what the consent model looks like, and we were receiving consensus to do that. Whether or not the CIE takes the same form, I guess we'll find out in the next several months.
For our work, oh, sorry.
No, please go ahead.
For our work, I'm not aware of lengthy legal processes. But again, we're working with different forms of data than the individual health information.
So is there, how about funding that community participation piece? Is that shared by different participants in either, the Boston dashboarding or in your CIE? Or has it fallen to one member to try to make sure that that is well funded and pursued?
I mean, I think to Chad's point, we're not there yet, but in terms of compensating consumers participating, as well as community organizations that serve them, that's part of the funding that we receive through a grant. So it's a little bit of a different question, I think, unless we moved off the legal piece, we're just not in there in relation to the legal piece yet. And I will say, I mean, we have, I mean, that is part of the work of the steering committee is to look at the ongoing funding pretty quickly, and we've certainly got healthcare sitting at the table, and so anticipate we're going to be asking quickly, like, how much are you willing to put in this, and what does that look like? So.
For our funding, the data work group was primarily a volunteer opportunity that people were leading and participating. We do have leadership pathways that are some of which are funded to our current data work group that's meeting now, which is developing a similar data tool to the housing tool you saw, has data ambassadors who are receiving stipends and are compensated for their time and their work. And so each group has worked a little bit differently, and also around the funding mechanisms for launching the different tech tools and data tools.
Great. Well, thank you. That's something that's pretty important to Dash as well, as we have provided some small funding for legal reviews and other, some of that outreach work, but we know it's not sustainable, and it's built into our framework that it should be sustainable, and very interested in approaches to managing that. So acknowledging our role in the unsustainability, but also hope that people have started to see some value across the different partnerships to making sure that data governance and community governance of your projects reaps a long-term reward. So finally, I think this question is for Millen. The question is, do you see common themes in horizontal and longitudinal or horizontal and vertical population settlements? And that's kind of over my head. So that's
yeah. Would you mind clarifying the question a little bit more, Debbie?
Hi, can you hear me? Yeah, the question is that, are you seeing something like a huge mass settlements, like a vertical building, and then across the city where you have common theme which occurs between the two, the concentration of populations in a vertical settlement, like a high-rise building versus buildings which are isolated? You see common themes which are more population-based versus having to do with concentration of population in one location. That's what I meant to say. Probably I just phrased it in a different way.
Yeah, that's a really great question, and something that I definitely need to look deeper into with the work group and get back to you on.
I think about this like, excuse me, I think about it like, suppose respiratory illness and how places are kept clean, for example, and the use of emergency rooms in the close by hospital. There's a correlation between the high rise and the number of patients put in a specific high rise building or in a zip code, for example. So I was thinking, is there something which is sometimes it is distributed across the population irrespective of settlement, or the type of settlement? There's vertical, that's like a high rise and versus individual house. So we can just see this as more prevalent in the population itself, or it is because of the location itself, or other reasons associated with the location.
Yeah, absolutely. I think that this is a continued question and process for us. With the asthma rates, we were working with the Boston Public Health Commission's Breathe Easy at Home project, which was focused on housing as an indicator and violations in housing as they relate to asthma rates. And so there's definitely been questions raised by the community work group around how housing impacts asthma rates, especially among children. And it's something that we're looking into. I don't have a great answer for you right now around the question of high rises versus low rises, like rates among the different, like specific different types of housing, but it's something that we'll look into.
Yeah,
Thank you for raising that question.
Is it equally distributed across the population, or is it something which is uniquely distributed because of location or conditions in which the people are living in those conditions, which are confined and endemic in a way?
I wish I knew everyone who was on this call, because I wonder whether anyone from the Minneapolis, I believe it was the Minneapolis Public Housing Authority, is on the call. This question came up in the work that Dash funded in that area for some of their high-rise public housing, where they actually engaged residents in a sort of data gathering or data sharing effort, and that led them to addressing some conditions and creating conditions for that type of housing to deliver better services to the residents, particularly the elderly, and be more responsive to that particular sort of micro community needs. So I appreciate the question, and it is something to continue to, I think, be mindful of, and part of why our framework is quite broad and yield so many different interesting approaches to various opportunities and challenges is that very thing, like the different ways that communities define themselves and show up and can share data for community purposes or for equity and health are just really still out there, remaining to be explored and realized. So it's an exciting time. So we don't have any open questions in the Q&A. We have a few minutes left. If anyone's hand is raised, I'm afraid I don't see it. But I would be happy.
You've got, and Lori is raising her hand. Oh, no. No. That was funny.
Well, thank you, Jess, for letting me know that older adults was the term I should have used.
Thank you for saying that. Yeah, I was gonna, if you raise it, just say that the American Medical Association has been very, very clear, along with the Associated Press and others, that particularly the term the elderly is like saying the poor or, you know, the gays. It's just othering and not helpful. So we ask to be specific, people over 60, and when you have to use a term, older adults is more appropriate.
Well, that is wonderful to know, to learn. Thank you so much. Thank you. Happy to take that kind of feedback publicly as well, if anyone else has things to share. Like I said, we are on an equity journey. We are certainly nowhere near a destination.
No, gosh, no.
All right. Well, that said, would any of you like to make any concluding remarks? We do still have a fair number of people who are listening in. Otherwise, this may be the moment to, yeah.
I have one more thought. What can we learn from resilient populations and apply that towards population with disparities? Again, is something which we see that if there's inequities, but the population is resilient enough to sustain, then how do we use that information which makes that sustenance to apply into communities which are with inequities rather? I'm just thinking in a different way, maybe that's
I'm sorry, I'm not sure I understood your question.
I'm thinking about a population which is resilient. For example, we see some communities within Native American Indian population. Some of them have become resilient because of experiences over time, have certain programs which instill them into resiliency. And how do we understand that information and apply to communities is useful? That's what I was saying.
And go ahead, Melon.
I want to push back on that a little bit, especially when thinking about communities and neighborhoods in Boston. The resiliency isn't really it's not that one population is resilient and another isn't. There's system level barriers that are causing health disparities in creating inequities. These are generational challenges that people have been facing. And so I think if you're thinking of resiliency as the measure, we should all be looking at systems level barriers and trying to remove those as a way to together as a community move forward.
That's great. And I was going to say something very similar, and then I had a different sort of question for you, which is like a different version of that for me was really, and I'm very interested in when you have moved to co-creating and empowered people to design and really lead these efforts and have seen the results. Do you see, and are you capturing how that's that sort of confidence actually in an ability to lead is moving into other parts of their lives and maybe community development, that kind of thing? I'm just curious, like, what's sort of the bigger impact?
Absolutely. I think we have leadership pathways for women that want to move into lactation consultant roles, or community leaders that want to take on greater responsibility and learn advocacy. We partner with city colleges and with other coalitions that are also doing this work. And I feel like I'm constantly learning from everyone in our network about what it means to be working for generations to remove barriers. And I think celebrating the bright spots is something that people that I don't take for granted anymore, that I'm really inspired by, people that want to celebrate progress that has been made instead of just looking at the challenges. And so in our data work and our mapping, we always try to highlight as I said before, the solutions that are in the community instead of just highlighting challenges.
That's beautiful. Thank you.
And it's a great plug for the next installment of this webinar series, which will focus on the role of policy and a multi-sector approach to creating some of that structural or systems change. So again, I'd like to extend my heartfelt thanks and appreciation to the presenters, the interpreters, and others on this call whose questions and observations have really helped all learn, I think, and all teach. We'll look forward to seeing you again at a date to be determined in September, and look forward to sharing more about our learnings and lessons along the way. Thank you all very much.
Thanks for including us.
Thank you very much.
Mm-hmm.